Thank you very much for those of you who have, stayed. I know it's the late part of the day, and a lot of information through the morning. So thank you for staying. So we are now to the last session. We have three speakers, and each one would spend about 10 to 15 minutes presenting their topic, and then we'll call them to the podium and then take some questions and answers. Okay, so the first presenter is going to be Dr. Hawthorne Smith. He's online. Dr. Hawthorne Smith is online, okay. Dr. Smith is the director of the Bellevue Program for Survivors of Torture and president, National Consortium of Torture Treatment Programs, who is also joining us virtually. That is his speech. He's going to be talking about wisdom, courage, and hope, effective interdisciplinary care for survivors of torture and forced migrant populations. And then followed by that, we'll have Ms. Crystal Miller. She's here. She's a holistic practitioner and clinical psychotherapist at Melanated Masks, right? That's correct. And then after that, we'll have Dr. Briggs, Asa T. Briggs, psychiatric nurse practitioner at Briggs Psychiatry and Behavioral Health. Will give his talk at the end. And at the end, I'll call all of them to the podium. I will take some questions and answers. So we'll start with you, Dr. Smith. Please go ahead.
Thank you so very much. And
15 minutes.
I want to thank the coordinators of this edifying and informative program for including me. And I salute you on behalf of the Bellevue Program, Survivors of Torture, and the NCTTP. I have no disclosures in terms of financial links with pharmaceutical companies, but I will say I have a significant amount of pharmaceuticals coursing through my body right now. I just had hip replacement surgery 2 days ago. That's why I'm not with you in person, but I did not feel that this was a conference that I could miss. So I just want to thank you folks. So again, I do represent the Bellevue Program for Survivors of Torture. We were founded in 1995, and to date we have treated more than 6,000, close to 7,000 survivors from all over the world. I think now we have actually crossed the barrier of 120 different countries worldwide. Our mission is to help rebuild bodies, the minds, the spirits of people who have been tortured, persecuted. And one of the things I just wanted to point out is that, as you see from these pictures, and Bellevue with its old history, but it's also a very modern hospital, that we really do value evidence-based practice. But we do not want to throw out the cultural wisdom, the practice-based evidence that we have acquired over the course of the years. We don't always have the luxury of placebos or control groups or what have you. And the focus on our interdisciplinary approach. And I think that this is what might make this most valuable to those of you coming from different domains. And the other thing is that we really take a resilience-based, strength-based approach to our clients. And we feel that our clients are survivors, which is much more than being victims. We feel that anybody can be a victim. Wrong time, wrong circumstance, wrong place. But to be a survivor is really more about a comportment, a real sort of validation of their strength and effort to hold on to the sense of humanity, even though it has been violent and purposely attacked. Next slide, please. Oftentimes, when I have more time, I would go through a number of these questions, and I start by asking people, have you ever voted in an election? Have you written an editorial, blah, 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 and I go through some of these things you see here. And maybe people will look at me kind of funny, like at the beginning of a presentation like this, who is this guy asking all these intrusive, borderline, inappropriate questions, perhaps? But the reason I do it is because if you can raise your hand or nod your head to any of these questions, if you identify as a woman, if you do have a sexual orientation that is other than heterosexual, any of these things that are here, oftentimes I am asked, who are these torture survivors? It's almost as though they are considered to be this sort of exotic other population. But if you could raise your hand, if you could nod your head to any of these or many other questions I could ask, I can honestly say that the people we are treating are people just like you, just like us. This is not about an exotic other. This is about us. This is about a sense of shared humanity and people who are facing such significant challenges. Next slide. So, among the challenges experienced, and again, it's a challenge to go through so much of the domain within 15 minutes. I'm going to try and do this so you get a sense of the context in which the treatment takes place, but also to really look at some of the ways and some of the best practices. So I'm going to go quickly. I'm going to do that New York thing. That we are not just dealing with PTSD, even though it's a very useful diagnosis at times. That we are looking at people who have been through social dislocation, whether that's been a rebel insurgency, a civil war, homophobic persecution, race-based persecution, whatever it might be, being in prison, perhaps escaping, living as an IDP, an internally displaced person in their country. Oftentimes escaping and making it across the border to another country where there might also be chaotic, impoverished conditions and where they might be seen as infiltrators or might be a xenophobic response. And then somehow making it to this country. We look at many people leaving West Africa and going by Pirogue and trying to get to Europe. People who are coming into Brazil, coming into Ecuador, and then making their way up through Latin America, crossing the Darien Gap, and just the trials and tribulations to even make it to our southern border, and then the political and social realities that they're facing now. And then coming to New York City and trying to engage, trying to adapt with us in New York and all of our infamous warmth and fuzziness. We are not talking about something that is post. We are talking about recurring, reinforcing stressors that really do serve to keep the trauma alive in the present. And the multiple losses and challenges that people are facing. And they will respond to this in many, many different ways. And we will get into that, but I just want you to understand this is about us. It's not about a particularly bad day back in the Democratic Republic of Congo. It is about recurrent and reinforcing stressors that we're dealing with today. Next slide, please. So physical and emotional scars. Oftentimes when I do this presentation with one of our PCPs or medical professionals and we have the quote unquote gory slide show or what have you, we're not doing that. But what I want to talk about is the interplay. That many times those of you who are medical practitioners might have someone in your office who is expressing some sort of paresthesia, some sort of physical response, but there's no etiology that you can determine, but it might really be from their emotional comportment and the trauma that they have gone through. It might also be that with the physical trauma they have gone through, we have had clients who have talked to us and said that some of these wounds might heal, these physical wounds or what have you, but oftentimes what is the most deeply felt are the emotional wounds. When someone talks about a mock execution and thinking that their life is gone, when we talk about someone who has gone through torture, but now is going through the asylum process and has been separated from their children for 6 or 7 years, that sort of pain, that oftentimes the emotional pain is even more indelible than the physical, but they work and really fuse and serve to multiply one another. So we want you to just really, again, think about this not as things happening in silos, but just multiple ways in which people are challenged. Next slide. So this slide gets a little bit more into it. These are many of the ways that people respond to torture, to refugee trauma, and I could put a lot more lobes on this flout if I had sort of stronger PowerPoint skills. But what I want you to really see is that it's not that the cognitive is over there, the physical is this way, the emotional is somewhere back there. They all fuse together, and we live, for lack of a better word, in the center of this flout, where one thing really can reinforce the other. So for example, if somebody is having nightmares or dealing with insomnia because of the trauma they went through, they may wake up in the morning feeling really tired, low energy, perhaps there are headaches, they might miss appointments with you, or they might come in late, or they're not able to hold down their job. These sort of ongoing social stressors can reinforce rumination. There might be difficulty in learning new things, that we can talk about the nature of traumatic memories and what trauma does to our ability to sort of capture new information, if we talk a little bit more. Frustration, depressive symptoms, this might lead to self-medication or some sort of maladaptive coping strategies. So for example, if someone says to me that they drink 1 or 2 beers a night, and that helps them get to sleep, for a sort of quote unquote typical New Yorker, okay, maybe that's not a big thing. But if this is someone who comes from the Muslim tradition, and I will say Eid Mubarak to all of you who are celebrating Tabaski and all of that this evening, this weekend, that someone drinking 2 beers a day, which is haram, has great meaning to them. So again, all of these things are working together and sort of buffeting the person. And so this is part of the bad news, is that at the individual level, there are so many stressors. Next slide, please. And then even in terms of how one might engage in relationships. And this will manifest itself when we are seeing patients in our practices. What is their ability to process information? What is their ability or even willingness to talk about memories with you? Can they relate to you? Do they relate with others? What do they think about the future? What are their feelings about the world? So sometimes we might put labels on this person is resistant, or this person is reticent to engage. But is it really about that? Or is it about the way that trauma has really impacted their ability to interact with others? Next slide, please. And then if we take it a step further in terms of the spheres of marginalization in a more sort of societal sense, educational functioning. When I got my doctorate, it was a big thing in my extended family. I was one of the first to do so. But if things hit the fan here in this country and I'm forced to flee to Haiti, let's say, not only am I no longer Dr. Smith, but my Creole is so non-existent that I become functionally illiterate. So again, this sort of levels of disempowerment. Legal advocacy. In our program, more than 90% of our clients who come to us are dealing with the asylum process, where they sort of have to engage in the legal system, even to claim their right to be here. The vocational, the professional, as our clients will let you never know who's driving your Uber or your Lyft, who's sweeping your floor, who's standing guard outside the 99-cent store in the middle of the winter. Many of the clients that we work with were targeted because of their leadership roles within their societies. And they were chased because of that, and now might be living as the 14th person in a 1-bedroom apartment. And social functioning, the way people are treated in schools and different things, there's a lot to be said here, but again, I'm going very quickly. So let's go to the next slide. Now, the previous slide showed about so many different ways that our clients are challenged. This one shows many different ways that we can approach healing. And again, making an impact in any one of these modes feeds back to the middle, so that someone receiving medical services at our clinic, they might not be interested in behavioral health services at first. Maybe they're not familiar with it, or maybe it is actually stigmatized in their home culture. But if they actually begin to see that, hey, I'm getting some tangible benefit from this program, and one of our medical providers says, hey, you seem to be really isolated, you're a French-speaking African survivor. Dr. Smith runs an ongoing support group for French-speaking African survivors. This might be useful for you. We begin to sort of work that way. When we look at the social and legal support, oftentimes in our program, the longest line is outside of our social and legal service providers. It's nice that I'm feeling better pain-wise, that I'm sleeping a bit better. I've met with the psychiatrist, but how am I going to normalize my status? How am I going to get my family here? And I'm proud to report that our success level for our clients who have applied for asylum now stands at 95%. We have helped more than 1,400 people get their asylum. But again, we can make a difference in any one of these areas. It makes a difference across the board. So the bad news is that there are so many challenges they're facing, but the good news is that there are so many ways to intervene across disciplines. And for those of us who are not practicing health care providers, I would say it doesn't have to be therapy to be therapeutic. Next slide, please. I was in Pittsburgh in 2018 after the vicious attacks at the synagogue there, and we were having community meetings dealing with some of the societal trauma. And one of the things that really struck me is that one of the attending physicians there talked about the general review of systems. that one learns in medical school and through practice. But he said, we need to expand our review of systems to be also a review of experiences, a review of context, a review of feelings, any way that we can really, again, make this an interdisciplinary approach where behavioral health issues and are not sort of separate, they're not a side dish. The founder of our program at Bellevue, Dr. Alan Keller, he always says if he had one question to ask, and he's a primary care physician, it would be, how are you sleeping? It's open-ended, it's direct, it's medically linked, but it opens the door to so many different ways of approaching if someone's dealing with nightmares, if they're having sleep interruption, if they can't sleep at night because they're so afraid they can only do so during the daytime. It's one of these things that we can do to help normalize the conversation. As you well know, the patient is the prime expert in terms of the pain they are actually feeling. We need to have that humility mixed with our expertise to learn from them so that we can move forward. Next slide. So, two of the things I just want to point out in terms of treatment priorities and techniques. One is around safety, one is around empowerment. Bellevue is very much like Kings County. I think that if you look up in Wikipedia and say, large, urban, chaotic hospital, what have you, and, this big picture kind of jumps out. Anything that we can do to help reduce the ambiguity, to make our physical environment more inviting for folks, but to reduce the ambiguity, what is it that we can provide? What can they expect from us? What are we expecting from them when they come to meet from us? Anticipatory guidance, again, letting them know what it is we can provide and helping to build trust. And very brief anecdote with this. I worked with a woman from Cameroon over 20 years ago, and this is someone who came from a fairly elite family. She actually had bodyguards from the time she was a child to the time she was a young adult. And when there was an attempted coup, a reversal of power, the people who actually turned on her were her bodyguards. So we were talking about trust and developing a trusting relationship. And she made it very clear to me that there was nothing I could do to earn her trust. She said, even if you say all the right things, even if you do all the right things, and you do them for 20 years, that's what my bodyguards did. But ultimately, they are the ones who betrayed me. So there's nothing you can do to earn my trust. I responded with silence. One, I thought it was appropriate. Two, I had nothing. But she thought about it some more, and she said, even though you may not be able to earn my trust, perhaps it's something I can offer because I really need the help. And it's something that really crystallizes in my mind. It changed the way that I approach what we do, in the sense that, yes, there is nothing I can do to earn someone's trust. There's plenty I can do to destroy their trust, but I need to accept their trust as a precious gift that is being offered and to cherish it as such. In terms of empowerment, again, putting ourselves in a place where we are working collaboratively with our clients as opposed to this expert sort of stance. Again, these are not just victims, these are survivors. Where does this strength come from? What is it that we can learn from them? Allowing them to teach and to share. Again, I work at a program where we've seen people from 120 different countries, and I will say there is no possible way to be an expert in country conditions in 120 different spaces. And I will say even more, there's no way to be an expert in one place to the level that that person sitting across from us is. Even if we have our own immigration experience from the same country, our experience is not theirs, and we need to be in a position to learn. And sometimes when we're doing, things, and I do most of my service provision in French, other languages, but when we're dealing with someone who is speaking to us in English, maybe English is their fourth or fifth language, and they might have feelings about it because they're not fluent. To even just put forth that as someone born in this country, as a proud American, I can say that I come from a country where we barely speak one language. And my in-laws in the UK will tell us, yeah, it's not English. I don't know what you New Yorkers are doing, but that is not English. And also just to point out, hey, if we were doing this in my fourth or fifth language, it would be a really short interview. So if I just might ask someone what languages they speak, and they say, oh, I speak Pular, I learned Quranic Arabic, I understand some Malinke, the colonial language is French, and I'm learning English, any way to help raise them in the hierarchy and let them know that they are valued and valuable. Next slide, please. And that we need to really alter, or at least be willing to consider altering how we engage with folks around the cultural norms. One of the things that we, I think, take a lead on at Bellevue in this field is around groups. I've been running a group for French-speaking African survivors. We're into our 29th year at this point, and it's gone beyond being a therapeutic group to really something they call la famille africaine, or even the baobab. And for those who are familiar in the village setting, sometimes it's the baobab, l'arbre à palabre, literally the tree of words, where people come together to share their experiences, to get advice and what have you. And by engaging this way, oftentimes people are more amenable to other services. It helps to give them a bond. And as they mentioned, and I think it's a Native American expression that sorrow shared is halved, while joy shared is doubled. And it really helps our clients as well to understand that they are more than just people who are needy. They are people who are needy. They are part and parcel of the healing experiences for others. Next slide, please. So just a few things, and I'll just grab a couple from here. Character versus circumstances. Many of our clients, as I said, have had so many losses, so many stressors. Maybe they're having difficulty learning English, even though they already speak so many different languages. There's a trauma speaks so much, but oftentimes we're able to talk about the notion of their character, the fact that they were intelligent people at home, if they were generous people at home, if they were socially oriented people. All of that remains. They're still intelligent. They are still generous, even if they don't have 2 cents to rub together right now like they used to. Socially oriented. The circumstances might change, but the more we can work to hold on to character, the better place we are to really engage and help to change the circumstances in a better way. You can never say, oh, things will be like they were before. If I do, I'm exaggerating, I'm going much too far. But I think that it's important. And the fact that this is a hard journey, it is, there's a lot of hard work involved, and what many of my French speakers will say is like, rien n'est facile, mais tout est possible. Nothing is easy, but everything is possible. And providing this sort of notion of hope is really beginning. And next slide, and my last slide, I hope I didn't go too fast or too slow, but this is where the title of my talk comes from. I was running a group session. Again, this is more than 2 decades ago. And there was a formerly enslaved person from Mauritania who was having a really rough time. And his family was in hiding. The asylum process was going much too slowly. Frustration was there. And he asked the question, what are the qualities? What are the characteristics that we need to change the world, or at least to survive in this world? And I thought that this is such a profound question. This group will never come up with a consensus. And I was wrong, as I frequently am. And the 9 people who were there that night, they came up with 3 things: la sagesse, le courage, et l'espoir. Wisdom, courage, and hope. And they went further. And they said that if we have 2 of these 3 qualities, no matter which 2, it's insufficient. Because if you're a courageous and hopeful person, but you lack wisdom, chances are you're going to go about your activities in a way that's ineffective. You'll fail. Conversely, if you're wise and hopeful, but you lack courage, you will never act on your volition. You'll never go forward with the things you need to do, and you'll be trapped in a prison of inertia. But as you've heard all day today, and I hope you get a sense from my talk, the wisdom is there. And I'm not just talking about advanced studies, but a cultural wisdom, education de base, as they would say, the courage to think about the things people have gone through, to come all the way here and start over at zero. We don't even have to talk about courage. But what is hard to hold on to is hope. And I thought that was it, but they went even further and they said, Dr. Smith, you have to understand that hope is not so much something you have, it's something you do. It is actually an active capacity to hope. It's an attitude, it's a comportment, it's a discipline. And they said that perhaps the most important thing is that that capacity to hope is something that can be shared. And when it's shared, then the people can use the wisdom and the courage they already have. Blew my mind. I remember it like it was yesterday. And it changed how I view what we do in the group, what we do in our program. And I think that what we do across our disciplines, in certain ways, we are in the business of sharing the capacity to hope so that people can use intrinsic wisdom and courage they already possess. And with that, let me again say thank you for having me, and I look forward to any questions you have.
Good afternoon, everyone. Hey, all right. I know it has been a very long day, so thank you again for being able to still be here and being present and still awake. All right, I know they're getting, there it goes, perfect. All right, if you see me looking down, looking at my notes, okay? And if you need me to speak up, let me know as well. So, I will be honest. I had no idea what to speak about today. I was actually very stumped about what I could possibly bring to a room full of people who are very well accomplished within this field, even though I've been in this field for like over 10 years at this point. But as I sat and thought about it some more, it allowed me space to reflect on how I even got here, to this point in my career, to one that is rooted in decolonization and liberation of our communities while using the wisdom of ancestral healing knowledge that science continuously tries to catch up to. And although I have not yet hit griot status or barely even auntie status by some people's standards, it is absolutely an honor that my childlike curiosity sits me at this intersection of both science and spirit, where the two worlds get to commingle in a way that feels good to the soul and authentic to the people that I get to serve in our community. And it has been such a pleasure to hear from my colleagues today, where we are pretty much on the same sentiment. That it's not simply the work that we do, but there is the underlying pieces that are affecting the community that we serve. So, my name is Crystal. Nice to meet you all. I'm a licensed clinical social worker by trade, including being a therapist and a professor at Columbia School of Social Work, as well as a holistic practitioner by ancestral path. Through my background in clinical and spiritual herbalism, yoga, integrative mental health, and newly as a womb practitioner and full spectrum doula, I get the opportunity to see the ways that trauma lives in our body, from our mind to our gut to our roots. And in 15 minutes or less, we'll talk not simply about trauma and how to address it, but also the system as a whole from a different lens. So, yeah, these slides are not going to be like we saw today, just so you know. By raise of hands, who here loves to shop? Perfect, me too. Completely ashamed of how many Amazon packages have come to my door this week alone. But, okay, next question. How many of you all side-eye a tag that says one size fits all? But we still go ahead and buy it though, just in case. Maybe you're the one size that fits it, right? And that's kind of why I have this very cute shark here, right? Quick anecdotal. My fiance decided to buy us some sharks because we wanted to be cool and corny. I am 5'6" and he is north of 6 feet. It fit neither of us. I could barely get my head in, and if you can get a leg in, that is a miracle, right? So this is what I think about when it comes to the systems that we work in. One size fits all could be really misleading if we aren't asking these right questions. So when we're talking about the medical and mental health industrial complex, I think of everything from our use of the DSM, diagnostic assessments, and simply the way that we approach a problem, where all of these are seen as one size fits all. And it's something that I've always known in my gut. And as I use more and more of these assessments or evidence-based practices while in the field, when dealing with people who experience various forms of trauma, usually young people at the time with various ACEs scores, but also the adults that were in their lives. It never accounted for nuance, for culture, and for ancestry. It forces us to see our clients through just one lens, as if it is the one. More like a magnifying glass and less of the multiple lenses that we use when we go to the eye doctor to see which one fits the best. And in doing it in that way, it forces our people into boxes that just doesn't fit right, much like this shark. All right, before I continue, show a really quick overview of what I'm gonna try to cover in about a little less than 10 minutes. All righty, so back to this complex. So it should not be a secret at this point in time that Black and brown people were not made for the system. As I hinted at before, many of the things that we use to measure was actually created to our detriment. Again, everything from the DSM to psychiatric hospitals. When it came to the breakthroughs that pushed the sciences that we use now, it was usually on the backs of the marginalized, and usually started with some level of ignoring the cries of the very people who came to them for support. And we won't even get to whether they were asked permission or consent. Though we know the names of some of these through history, such as the Henrietta Lacks, the Tuskegee syphilis study, for sterilization, we are not that disconnected from the reality that we currently live in. There are many studies and anecdotal evidence that shares the same themes. Black and brown people continue to not feel seen or heard within the medical and mental health system. It is the thread that connects the past to the present. So what does it mean to neither be seen or heard? To be a number instead of a soul? Well, if you ask the community, it might sound something like this. And I quote, "You talk about mistrust. How do you, as a Black person, sit back and say, what does care look like when you've never had it before?" End quote. Or, quote again, "I understand more that we as Black folks have become so intimidated by somebody that we think knows more than we do about our bodies that we just sort of sit there and take it, go somewhere quietly, and suffer. That's what they want us to do." End quote. Both of these quotes were taken from a recent study from the Massachusetts Health Quality Partners from a January 2025 statewide patient experience survey. These were shared to remind you all that re-traumatization rears its head every time a person goes unheard. Intentional or not, the harm is there when their words fall on deaf ears. If they can't trust their providers, who can they trust? So it's easy to simply see the people that we work with as numbers, unfortunately, especially when we are working within these systems that value quick visits, insurance panels, and other funding sources. So I would love to share an author with you that I fell in love with recently, Dr. Jennifer Mullen. She's a psychologist and author of the book Decolonizing Therapy. And she says it best, and I'm not one to really read off the slides, but I'm gonna read off a bit today for us. So she says the Eurocentricity and privilege of our clinical practitioner-oriented programs focus more on what is defective with the mind as opposed to one's experience. The belief continues to pathologize the person seeking help. We have been taught to medicalize and treat symptoms, yet we continue to ignore the soul wounds of historical trauma and colonization. We victim blame by focusing on personal deficiencies in trauma rather than structural violence. There is an unspoken yet deafeningly loud cry from our community to see them as their full selves, not just as an individual, but a member of a community with shared history. As we should, as we always should have. Because that is what allows us to see things such as community trauma, ancestral trauma, their lineage of health, societal ills, systemic barriers, and then looking at their experience of it and how their body has been responding. That then becomes the missing key. How do you get to know their full story so that we could best support the full person? Because the reality is, some of our methods or treatments serve more as a Band-Aid, that one size fits all. I couldn't tell you how often I've heard from people who get told by professionals that what they were experiencing was just stress and told to just deal with it. I was one of those patients. Many things get brushed under the rug as routine. Yet no one questions why these things are so common. What am I not hearing right now? And when it comes to trauma, what is the bigger picture of this story that could bring more clarity on how I'm approaching it? So when we're talking about trauma, I'm throwing around a lot of terms right now, so let's go ahead and define some of these. So starting with decolonize. And first off, before we get to decolonize, I'm gonna go back to Dr. Mullen to talk about what the colonization has been. So here, colonization refers to the behavioral, psychological, institutional, political, spiritual, interpersonal, and economical methods that have exploited and oppressed indigenous peoples globally, historically and present day. So when we're talking about decolonizing, we're talking about the undoing of these colonial influences. We're asking the questions of who's writing the history, who wrote our manuals, and what makes what we do evidence-based. I've always asked this from day one when I started getting evidence-based manuals. Who did they study this on? Because some of the work that I was using would not have fit the population that I was working with. And for context, I was a school counselor using books based off of like substance use and prevention, and using that in Far Rockaway, where Far Rockaway is predominantly Black and brown, usually of immigrants. If I did not twist them and made them a lot more personal, my kids would have laughed me in my face. Still loved me, but also laughed in my face of what I was doing to them. So we should always ask these questions. Who was it made for? The next one we have here is trauma conscious, and I'm using one of my teachers and her definition. So Natita Gessel, who's also a licensed clinical social worker and the creator of the trauma conscious yoga method, describes trauma conscious as embodied, intuitive, curious, and honoring the lived experiences of the people that we're working with. All right, so what does it actually look like in practice? So this is where we get to be integrative, holistic, and comprehensive. Okay, so this first slide is talking about if we cannot name the thing, we cannot fix the thing. We cannot address it. So this looks like naming the white supremacist and capitalistic structures that we're working with and how it is directly or indirectly impacting our clients. It looks like naming and recognizing the policies that are impacting the clients. And if applicable, really looking at their migration stories. And yes, this is also including those who are foundational Black Americans, and looking at what was the migration story and how has the family told that story throughout the generations, because that also still connects the thread. The next one here is looking more at the larger scale. So we're examining the role of community trauma, whether immediate lived community or that of their ethnic, cultural, and ancestral communities, including the LGBTQ community. We're looking at their spiritual practices, whether organized or otherwise, which are also important to know about their holistic wellness. I'll pause here for a second. Whenever I'm looking at integrative care, as was last mentioned by the doctor, spiritual wellness has to be a part of that too. there are going to be some things that we are probably hearing from our clients that may not show up in a test. And that is where our community healers come in, but I'll get to that in a moment. And lastly, looking at that complete historical narrative for context, right? So we're understanding the levels of personal, community, social, political, and ancestral knowledge is key to their holistic care. And as we're talking about trauma, there is a lot of strength happening within these different parts and sections of these people as well. So maybe something that has helped me that could support you all. If you weren't pathologizing, if you weren't diagnosing, how would you support this person? If you didn't have to worry about putting in that IC code, what would you do? All right, so this is where we start expanding our field. And it's important to have alternative healers on call to address what may be outside of your own scope. So when we're talking about somatic practices, we're looking at those who practice Ayurveda, traditional Chinese medicine, yoga, herbalism, acupuncture, and other body-based practices. Where I know it gets a little controversial, there's also the soul practice as well. So we're looking at the spiritual healers. We're looking at those even beyond being religious heads. So those include the curanderas, the shamans, the womb practitioners, and others within the African and indigenous communities. These practitioners help us to see the things that we may not be able to see with our medical tools. Because oftentimes the traumas that we are addressing isn't just skin deep, it is etched in our spirits and the deepest parts of our bodies. This is how we get there. All right, so let's start moving, I was about to finish up in a second, from our logical mind to our wise mind. So what does it look like now that you all can carry with you all after today? So the calls to action. First is that one-on-one is key. Meeting them where they are. These are things that we already know. Meet our clients where they are. This may also look like revamping your intake process to include questions about their migration stories and their community and their spiritual practices, as well as their current stress management. This is also something I share with my students a lot, is PROP. So this is looking at privilege, race, oppression, and power. The who, what, when, where, and how that is impacting the individual sitting in front of you in that moment. Because I could assure you that there is an intersection that is there. There's quite a bit of overlap. And the last thing here is the co-created care. First and foremost, trusting their body and their word. One tool that I've started to use recently was called pod mapping. And pod mapping looks at the entire community at large for this individual, for them to be able to name it. And it's outside of like, okay, my doctor here or my therapist there, but also my community center, my herbalist down the block, or the person who makes all my green juices. Those are all a part of their pod. We already know that we're coming from communities and working within communities that do not have a greater access of care. Using pod mapping and being able to sit with your clients in this sort of way allows them to identify who do you actually have and how can we help them in planning that. That could also be the social worker in me, and that's okay too. All right. So before I wrap up, because I know we're going to be doing questions in a bit, nothing I shared here today should be a standalone. Science and spirit has an overlap. They play well off of each other if we allow them to. And the Venn diagram here is much more of an overlap than we think. So I do hope that today, in addition to all the amazing information that you have got, that you are able to leave here with curiosity to tap into your own history and healing within your families as you rethink care that we allow as valid for people that we serve. Thank you.
Good afternoon. Looks like I'm the last person that is standing between you guys and the train, or you all in your mode of transportation. So I'm Dr. Asa Briggs. I'm actually a psychiatric nurse practitioner, and I came all the way from South Carolina today. So I'm going to take my time. I think this is also telling that mental health is oftentimes the stepchild in the room. So maybe next year we can change the order of operation and put mental health woven into the other presentations. So that's just my little soapbox. I don't have any disclosures this afternoon, so I'm going to get right into it. Really looking at the significance of culturally informed care for vulnerable populations with mental illness. Let's see. All right. So here are the objectives for my talk: to understand the impact of mental health challenges, explore barriers to mental health care, highlight the need for contextualized models of care, and then lastly, encourage vulnerability and transparency in healing. I typically don't read from my slides, but I feel like I should at least try to look at my slides this afternoon because I think this is such an important topic and I want to bring gravity to this conversation, even though we are at the end of the day. Looking at prevalence of any mental illness in America, in 2020, there were an estimated 52.9 million adults aged 18 or older in the United States with any mental illness. And this number represents about 21% of all adults in the U.S. And the prevalence of any mental illness was higher amongst females than males. And then young adults aged 18 to 25 years had the highest prevalence of AMI at 30.6% compared to adults aged 26 to 49 at 25.3 and age 50 and older at 14.5. I can anecdotally say that some of the data that is bared out here with 18 to 25-year-olds would be COVID-19 and social isolation. So I think about that a lot. I see that now in my care, especially with this population, because they spent most of their formative years in isolation. So we're seeing a lot of deleterious impact and changes in the mental health of that individual population. Looking at the prevalence of AMI was highest amongst adults reporting 2 or more races, followed by white adults at 22.6%, and the prevalence of AMI was lowest amongst Asian adults. Maybe they have the secret sauce, so we need to talk about that. Mental health services for AMI. In 2020, amongst the 52.9 million adults with AMI, 24.3 million, 46% received mental health services in the past year. So this is really telling of the dearth of resources in our community. I think this is also very problematic for us as we think about the topography and the changes of mental health and the crisis that we're currently experiencing. I think that as we sort of encourage people to come into the healthcare arena, we need to really think about individuals who are interested in mental health and behavioral health. Some of the disparities that we notice with individuals who identify as African American or people of color, oftentimes they come into a system, and I say a lot in my talks, is that racism, sexism, and the like don't stop because you put on a white coat or that you put on scrubs. I think those nuances, those presuppositions that you have about the people that you serve, it doesn't stop because you come into a clinical setting. And so looking at the impact that, as many individuals have said before me, that racism has on individuals in the healthcare system. Mental health services is no different. So actually, individuals who identify as African Americans are oftentimes looked at as less likely to understand medical information, so therefore their providers don't give them evidence-based practice. That is very harmful to the individual. Oftentimes, they are throwing everything at this individual, really messing up opportunities for them to continue in mental health services, because oftentimes these people don't come in to care but once, and then they see that cultural competency, which is a word that has been thrown around a lot today, but dare I say cultural competency often looks like the perpetuation of stereotypes. So I love the idea of cultural humility and cultural safety, meaning that you don't look at, as Dr. Hawthorne said, is that you don't look at individuals from marginalized communities as the exotic other. You don't want to look at them as being the problem, but thinking about the ways in which your culture has exacerbated the symptoms that these individuals are presenting in the clinical setting. Oftentimes, African Americans are over-diagnosed with schizophrenia and bipolar disorder, which carry a more stigmatized label, if you will. Oftentimes, this puts individuals at jeopardy of not being able to go into the workforce, not be able to stay in public housing, and really sort of perpetuate some of those social determinants of health and health outcomes. Looking at opioid use and illicit drug use, the African American community is slightly higher than the average, with rates of alcohol use slightly lower than the national average, including heavier drinking and binge drinking. So again, thinking about the fact that African Americans are not studied in the literature, oftentimes the things that we're asked to do from a clinical guideline perspective have not been studied in the population because context does matter. So I love the fact that Ms. Miller before me said that oftentimes we're looking at individuals from a lens of pathology and we're assigning pathology where there isn't any. And so that is really sort of one of the things that I think that in the South in particular, when you think about racism and you think about redlining and housing and things of that nature, is that people have been pushed to the margin. And later on in my talk, I'm going to talk about marginalization as a means of understanding why people are mentally ill and physically ill. I think I talked through that. Health-seeking behaviors, really important for us to understand. I love how Dr. Beverly talked about this morning, the patient that she had that didn't want to miss church. In the South, everybody is cultural Christians. I mean, it just happens. It's in our DNA. And one of the things that I'm doing in regards to that is really reaching out to the churches and looking at community-based interventions for individuals who come from marginalized communities. Pastors and church leaders are oftentimes the individuals who give people permission to talk about mental health and the disparities of inequities in healthcare. And so I think one of the things that we need to talk about is religious ridicule as it relates to health and health outcomes for marginalized communities. And then lastly, oftentimes African Americans or individuals who identify themselves as people of color oftentimes talk about their mental health challenges with their primary care providers. And so part of my work is to inform primary care providers on best practice and evidence-based standards for individuals from marginalized communities. Thinking about the barriers, oftentimes I hear people say they don't have adequate transportation. We understand that there's an administration now that is really working to minimize and to get rid of a lot of the Medicaid, Medicare services. And so individuals who were once given access to mental health services are now having to go to the ER, emergency rooms, et cetera. And so I think that what we need to do is make sure that we advocate for those individuals and advocate for the healthcare system to not get rid of Medicaid, Medicare in the way that it is projecting, because I know that where I live, Medicaid, Medicare is the #1 provider of healthcare services in rural South Carolina. So the impact of what I'm seeing in the administration is very heavy for me. In terms of lack of transportation, inconveniences, I hold longer hours in my clinical practice because I understand that people don't have the privilege of going to the doctor during the day. So I stay open sometimes 7:30, 8 o'clock in the evening, just to make sure that I lower any barriers of access to care for these individuals. In terms of stigma, I think I've talked about that. One of the things that we need to think through is perceived ineffectiveness. Oftentimes, because people are not used to being heard or have agency in these kinds of conversations, they don't believe that mental health clinicians really care about what they're going through. And subsequently, they withhold a lot of the information during our intake process that will really be beneficial in their health and health outcomes. I just spoke briefly about this earlier, and I'll mention it again. Marginalization really uncovers health implications and social ramifications based on the magnitude of marginality. And so the intersection of marginalization and social determinants of health defines one's health, one's social position, and it links the two variables together. So marginalization really sort of helps us to understand that we talk about food deserts. Deserts are actually natural occurrences. I love the language of food apartheid. I know that this is not a novel statement here in New York City, but as we think about grocery stores that are closing down and lack of resources in the South, people want to call things deserts. And I'm like, no, these are intentional systemic issues, and people are intentionally closing these things down and putting us at greater risk of poor health outcomes. Thinking about steps toward health equity in diverse cultures, we need to understand. I love the fact that Ms. Miller talked about not one size fits all. So engaging in communities that live at the margins to hear what they have to say about mental health services. How do they engage their mentally ill? What do they think about those things culturally, religiously, et cetera? We need to do a better job of doing community assessments. Oftentimes we're going into communities and we're implementing programs that have not gotten the necessary approval or the stakeholder buy-in to make sure that these programs are sustainable. Training, again, the dearth of psychiatric services, the gap of psychiatric providers that are coming into the healthcare system are continuing to grow year after year. And so we're seeing medical schools that are not recruiting or medical students who are not interested in psychiatry. Same as for nurse practitioners and physician's assistants. So we got to do something in terms of our training. And then when we train them, again, going back to the cultural competency that we've talked about, we need to think about cultural safety and cultural humility. And then acknowledging the fact that marginalized individuals have been impacted by majority culture. And so when you acknowledge that your culture is implicit in some of the things that are showing up as pathology, as you are assigning it, it really sort of changes the conversation for the individuals. Community mental health and reducing disparities. The Biden-Harris administration in fiscal year 2022 really invested in community mental health centers and community-based interventions. And so now we have an administration that is actually rolling a lot of that back. I think in Alabama it was overnight there was a NIH grant of upwards of $10 million or so. And so individuals came to work in community-based mental health centers and were turned away, and subsequently had patients that were abandoned and lost to care overnight. So these things are happening, and they're happening in real time, especially in the South. Thinking about contextualized models of care, we have to move away from this idea that one size fits all. So we have to think about ways in which, and this is particularly important for African American men and how we show up. Healing circles are cost effective. Thinking about ways in which we are not thinking of ourselves as individuals oftentimes when it comes to mental health, because you don't want to be perceived as crazy. You don't want to be perceived as having an illness that other people are going to stigmatize you or further push you into the margins. So thinking about ways in which people can come together collectively and heal collectively from the collective traumas of America. So I heard that this conference was held in Haiti. And so I had the opportunity to go, I think it was like 8 years ago, because one of the things that I'm very interested in is the globalization of contextualized models of healthcare. And so I had an opportunity with 2 other providers from Notre Dame to hold what we believe to be one of the first psychiatric clinics in Haiti. And this place is in Léogâne, and this young lady here is holding a plant and talking about healing practices. She has understood that oftentimes big pharma doesn't come into places like Haiti. And when they do, they drop off medications that are not sustainable and continuity, and they don't really ask the questions of what have we done to make sure that we take care of those individuals who are mentally ill. And so there are a lot of herbs and a lot of things that we're putting into our bodies that are not helpful to our mental health. And so this young lady was very keen about the things that were available readily to treat people with psychiatric illness. And that is something that I encourage as I was there, because we had Prozac that we had brought over from America and Trazodone and things of those nature. But when that medication runs out, what do? We started treatment, and then we've left that patient to their own devices. And so working in collaboration with the local healers and the people who have been doing this work, I think is very, very important. And look at, this was a line that came, it went off of the picture. And people were walking for miles and miles and miles to talk to us. And we stayed there for 5 days, and I promise you, we saw over 800 patients, some of whom we could help and some of whom we could not, because the acuity level of the patients' presentations were such that we had to help them to get to the only inpatient psychiatric hospital, which was Mars Klein in Port-au-Prince. So we really are fortunate in this country to have access to some of the best inpatient and outpatient ambulatory services for psychiatry, because when I look at this picture, I'm reminded of the fact that not everyone has that. This was some of the nursing students. Also very keen. I'm sorry. I'm also very, you guys are awake now. I'm also very keen on the fact that indigenous people need to be serving people from their countries. I don't think that Western philosophy needs to be overlaid in cultures where we don't belong. And so one of the things that we were working on was trying to get certification for nurse practitioners to provide psychiatric services to the folks that we were seeing for continuity of care purposes. Unfortunately, due to the increased rates of suicide, we were unable to continue. Notre Dame did not want to continue that program with the liability of the increase in suicide. So here are my references, and thank you guys for allowing me to talk a little bit longer.
All right, thank you to our speakers. Now the panel is open. It's time for the questions and answer session. Please make your questions as brief as you can.
Good evening. I just met Mr. Biggs, and I told him I'll be here till he speaks, so he's kept me here till the end. Just a brief comment. I've learned a lot of things today. I'm an associate professor of medicine at Howard University. I've been practicing medicine this year, makes it 40 years. I'm glad I'm about to retire because I don't understand what's going on. Who is a spiritual herbalist? I came from Nigeria 40 years ago, and I know there are herbal things you use. Are they scientifically proven to work? So what is a spiritual herbalist? And for you, what is the best way to find a mental health provider without being identified? Like if I wanted to see you without being open, I mean, how do you get, because that's part of the problem. People don't want to be identified as mental to see a mental person. So that's the question. What's a spiritual herbalist? And can I be your partner?
Of course you can. Okay. So for spiritual herbalism, the reason why I went this route.
The microphone is not on.
Oh. It is on. Okay. So the best way I could think about describing spiritual herbalism is looking at our indigenous and African practices and recognizing that, and I love that you showed the picture earlier of the Haitian woman who was using the herbs. It's recognizing that every plant that we have access to has a story. It has wisdom for us. And it has been used in such a way throughout generations. I very well could have went just the straight clinical herbalist route, which would have been much more palatable for people. But it was very important for me as someone of West Indian descent, I'm of Jamaican descent, to learn the practices of my people that has got us to this point. So I apprenticed with a very well-known herbalist right here in Brooklyn, Empress Karen Rose, who was able to teach me not only the clinical aspects of the herbs, but also how it was used to support the spiritual needs of the people that we were working with. Because sometimes it's not just working with high blood pressure or working with, digestive issues, but it's also how do we support someone who's going through grief? How do we support someone who's going through sexual trauma, who is learning how to get back into their body? And that's where the spiritual piece comes in. So in short, it's really just using the practices and knowledge and the wisdom that we already had within our cultures that, sometimes we haven't touched into it and it is at risk of being lost.
Yeah, and thank you for staying. I appreciate that. I told you that I think it would be available online, and you insisted, so I appreciate you staying. But I also, I think that how we can sort of find a provider without talking about it loudly, one of the silver linings that came out of COVID-19 was telehealth. So you can literally be in the comfort of your home now, and no one know that you're talking to any sort of provider. And so I think that that's one of the ways in which I think South Carolinians, in particular in my context, have really sort of made mental health a priority now, because they're not showing up in buildings that are not nondescript, or to the local mental health center where they know that their family members might be working and have access to their medical records. So now with the push of telehealth and telepsychiatry, there are patients that are coming from all over the rural South that are talking to me via their cell phones. And I think that's one of the ways in which we're lowering the barriers and increasing health outcomes for individuals with psychiatric services. And
Dr. Smith, you want to add to that question?
Certainly. I think that a moment for optimism. We've seen, for example, with the Francophone African group and people being referred to our program at Bellevue and all the stigma and everything that we've been talking about. And when we first began, most of the referrals were clinical referrals, coming in from other health professionals, legal professionals, et cetera. But over time, that has really shifted. And what I'm finding now is a grand majority of people who are being referred for our services within a big, centralized hospital are from within the community. And people now that we have this track record, I get stories every week, people like, I saw someone on the subway who just seemed so despondent, or they were crying, my sister, what's going on, and talking about these things and sending them. It really normalize, and to not put things in a thing like, oh, you're sick and you need help. Again, we're not dealing with sick people, we're dealing with a sick situation. It's not abnormal people, it's abnormal circumstances. And I really feel that little by little, it's moving us in this direction. And it's one thing, to have a group that's been running for 18 months. That's quite that's quite an accomplishment in this environment, in this setting. But to have one that is now pushing into 29 years, that talks to the strength and the buy-in of the people who are engaged in the group. It's not my expertise as a group facilitator. It's because it is now theirs. And I do believe that hopefully that is a model that can be shared elsewhere.
Okay, we have another question. Please go ahead, be brief.
Yeah, yes, of course. Hi, thanks again to all three panelists for very interesting and entertaining presentations. Dr. Briggs, I do share your sentiment that mental health should play a much more pivotal role in conferences like this. Two questions. One for Dr. Briggs. We are in the digital age, and I am not a conspirational theorist, but I do believe that we are in an age whereby there seems to be what I call a capitalist type of social engineering, where people's minds are being manipulated and changed. I've been an educator for 20 years. I now teach online, and I could tell you that there are serious mental health issues. So I wanted to know from the psychiatrist or psychiatric profession, what sort of adaptations are being used or developed or even contemplated to try to address some of this cognitive and mental kind of decay that seems to be going on. And for Dr. Smith, this might be a bit controversial, and I looked at the theme of your presentation. I come from a very small island nation, and we are very warm-loving people. However, we are faced with a migration crisis. And this is from a larger nation right next door to us, Venezuela. And what happened is that whilst we want to have a very humane, empathetic immigration or asylum policy, it's impractical with the kind of capacity constraints that goes with a small island. So in terms of your experience, what do you suggest that we do to craft a humane type policy that can meet and deal with some of these traumatic issues? Because most of the people are economic migrants and not necessarily asylum seekers. And I want to make that clear. An economic migrant is not an asylum seeker. Yeah? So I hope my points were clear and you understand what I'm asking.
I think you were very clear. So thank you for that. Yeah, I think that technology and the advancement of technology is not something new. It is not our age problem. Ever since the advent of any sort of technology, individuals have had to make adaptations to that technology. In the age of misinformation is my concern. In an age where there are alternative facts or people are making up facts as they go is the issue. And so the thing that I'm really sort of encouraging my patients to do from a psychological perspective is to turn off social media, to turn off the news, and be a consumption of community and personal interaction versus going to the internet for your socialization. And until we get back to living room conversations and connections, there was a recent study that said isolation is as worse as smoking 15 cigarettes. Did you hear what I said? I said isolation and being alone is like smoking cigarettes now. And so we spend so much of our time consuming information from the internet and social media that we're actually doing ourselves a huge disservice in terms of our health and our health outcomes. So technology is not the issue. AI integration is something that I think that all of us can agree in this room as healthcare professionals that it has actually helped us to do our jobs more effectively and more efficiently. So it's not the technology or the mind manipulation. I think it is the overconsumption of social media, and we don't have an appetite of socializing in person-to-person situations now. And I think that that's the thing that we need to concern ourselves with.
And then the second question, I believe, is Dr. Smith about the
Yes.
how can we create these what he described as practical solutions.
Yeah, I got it. I got it. And I think that one of the challenges that we face, but also one of the blessings, is that as service providers, as people who are engaged in the healing process, that is the crux of what we bring forth. Now, of course, this is partially determined by social determinants of health, and it has great impact on those determinants of health for the larger community. But I think that sometimes, and I draw a parallel to our engagement in the asylum process, I always tell my clinicians, our trainees, that we are not there to convince the asylum officer, the immigration judge, one way or the other, but we are there to shed light where there may have been shadow, to provide nuance where there might have been a lack of clarity before, so that those adjudicators and decision makers can make a more informed and just decision. And I sort of take that in terms of policy as well. That in terms of what is going on with your nation and the influx of people, what is the humanitarian need, what is going on, what is the pain of particular people who are coming, but then if there's so many people, what is the impact on society? These are things that you and others in the service providing field can shed light, can provide data, not just the quantitative data, but the qualitative, spiritual. Here's what's going on so that your adjudicators and decision makers can make a more informed and just decision. So I don't mean to pass the buck on that, oh, we shouldn't be the ones telling them what to do, but it's not effective when we do that. We become more advocates than experts. And I think we need to lean into our expertise so that not only are we listened to in this particular discussion we're having, but downstream, we will continue to be listened to and continue to have impact so we can build this frame.
Okay. All right. You have a question? Be brief.
Okay. Is the mic on?
This will be our last question.
Hello. Okay, sure. My name is Stephanie. I'm a board certified family nurse practitioner with specializing in maternal child health, and I also do a lot of alternative energy work. And I just have a question for you guys. I wrote it down here. Can spiritual practices be protective factors in communities facing mental health disparities, or are they sometimes dismissed as delusional or unscientific by providers? I ask that specifically because in doing womb work and Reiki, I'm a Reiki master as well, healing work, I hear so many different stories, and I feel that there are a lot of clients who are afraid of the stigma of maybe having spiritual gifts or things that can't be proven by evidence. And I was just wondering if you guys have any insight or any experiences, anything that can relate to the question in regards to that particular area of the disparity.
Absolutely. I think you hit the nail on the head by recognizing, bringing up that when people have certain gifts, that they're oftentimes dismissed very often. And I've seen that even with people who are looking for me as far as like providing care, that's one of the first questions that they ask me, like, how do I deal with people who come from other spiritual practices, are from other cultural practices. And one thing for me in understanding that is that I invite all of that into the room with me. And it kind of goes back to accepting their word for what it is. And again, not trying to pathologize what they're saying. So if I have someone who does come to me with some kind of like clairvoyance or anything else like that, it's accepting like that is your spiritual gift. How do you get to work with that? How has that helped you in your healing? And not just dismissing it as schizophrenia or anything else like that, because that is, again, how the re-traumatization happens. Because a lot of those diagnoses that we have to use within the DSM is because all of these other gifts that we have been dismissed. So for me personally and other practitioners who I work alongside, we accept that into the room because we know where it's coming from. We know how it has been used within our cultures and in our communities, and it is a powerful tool for them.
And I'll just say briefly that religion in the South is a protective factor for sure. But I think one of the things that I talked about briefly in my talk was religious ridicule, and it is not just enough to pray it away. I think a lot of people think that they can rely on their religion to pray things away that are not necessarily demonic or spiritual in nature when it comes to mental illness. And this is, and I don't think in my humble estimation that is true in any other part of medicine except for mental health. You don't tell people to pray away hypertension. Some faith traditions do, but not largely. Or you don't tell people to pray away diabetes. But when it comes to mental health, and we have a poverty of knowledge in this area, and the low-hanging fruit is to assign it to spirituality when there may not be any. So I think on the one hand, it's a two-edged sword. It's the spirituality can be protective in times of trauma and, in times of wanting to be comforted, but then also I think the misuse and abuse of that can look a lot more damaging to a lot of people. And that's why I think folks don't come to me sooner than they should, because they've prayed, they've gotten the oil, they've gotten in lines, they've given their money toward these things, and they haven't gotten the outcome. And it really is deflating for their faith, because then they say, we're not faithful enough, or God didn't hear our prayers, and therefore this must be some sort of punishment. And so I love spirituality, and I think it's really useful, but I think just like anything else, it needs to be governed in a way that looks like science and spirituality working in tandem with each other.
And that's that middle ground piece, right?
Yeah.
Oh, sorry. Looking at this spiritual bypassing versus like the complete ignoring of everything else, right? Because even with everything that I mentioned before, if someone needs the medication, take the medication, and we could still use everything else to support the full person. There has to be that balance and middle ground for sure.
I really applaud those responses, and I feel that there have definitely been times people I've worked with who have leaned more into their faith as a very constructive and supportive factor. There have been others who have had crises in faith due to the trauma that they have been through, and why has my God abandoned me, or such other sort of questions. And with, for example, with the Francophone group, where we have Muslims and Christians and Hebrew Israelites, people who follow what might be considered more traditional sort of faiths from their particular homelands, that oftentimes the sort of edicts of a particular faith are pushed aside, and they focus much more on the spirituality. And I almost like they do this work in themselves, like, what is a sort of divine commonality that is here, and have worked really wonderfully there, and it feeds into that sort of community support. And what Ms. Miller said, many people, it's not even practices of their faith, but perhaps it's communication with the ancestors, cherished loved ones, in the dream state, and what they hear in the dreams. And am I crazy to think this, but when someone worked with a woman from Sierra Leone who had seen her family murdered in front of her and was, sort of chronically, passively suicidal here, what have you, and having dreams where her mother, dressed in white, would be next to her in the bed to reach out and calm her and say, we're okay. We need you to be okay. You have work to do and all this. Would I ever look at that and say, oh, that's a psychotic process and this and that, we need to, not at all. This was an adaptive, constructive, spiritual, holistic thing coming from her. And I felt like I was privileged that she would share that with me, to be able to support her to move forward and see her progress. Yes, there can be pitfalls, there are challenges, but this is not something we should shy away from. This is a discussion we should be engaging in with our clients, again, from a very humble perspective.
Okay. This concludes the 8th Annual World Health Conference, co-sponsored by Health First. Thank you very much. Medinover, thank you very much, and Harvard University. And the College of Medicine at SUNY Downstate. So I now turn the conference over to Dr. Paul for closing remarks. So thank you, panelists.
Well, I'm not going to keep you guys any longer. Thank you for giving up your day to be with us today. I'd like to thank our partners, SUNY Downstate, Health First, Howard University, especially the moderators, Dr. Salifu, Dr. Pinkett. Usually now I wear my other hat as beggar-in-chief for Medinova. We have a QR code. If you have an opportunity to take a picture, no amount is too small for us because whatever you give adds to what we have. So I thank you once again for coming today. One last thing, I don't know if Elizabeth is here, Angela. I'd like to introduce you to the backbone of this conference. We're missing Raymond. But Elizabeth, can you stand, please? Angela? Without them, this wouldn't happen. Okay. I thank you, and also the partners from Downstate this year, Dr. Straker, Edlin, all of them. I think. Oh. So get home safe, drive carefully, and thank you, and we'll be here again next year.